Welcome to Green Time. I'm host Don Fitz. This episode, we're going to be talking about a broken system, the effect it has on healthcare workers. And with me, I have two people who know a whole lot about the healthcare industry. I have Dr. Pam Gronemeyer, do I have that correct?
Right.
And who is a physician and has her own private practice. And I also have Mimi Signor, who is a registered nurse and you are head of Missourians for Single Payer. Do I have that? That's
yes.
Right. Okay. Well, the first topic that we want to talk about with this episode is best standards of care. What are best practices standards of care? I'm not familiar with that term and that concept, but that's something we should be covering.
Well, each practice has a standard of care, and this is really just guidelines by each profession that says this is how you treat congestive heart failure, this is how you treat a broken femur, this is how you treat certain
guidelines for treatment.
They're consensus treatments,
okay,
whereby they've looked at different practices, and actually usually they're developed by different, like the American Board of Internal Medicine will develop one for. I mean, they're supposed to be best practices, like what tests do you do when somebody comes in for sepsis,
right.
And I mean they're really, basically in a way they're sort of like some doctors think of it as a cookbook, but they really are good guidance to remind people of what to do in order of diagnosis.
If a patient comes in and has lung cancer, there are certain guidelines for treatment that, if you practice according to your professional guidelines, you would do certain things. It should be more than a cookbook, sort of a rule book.
Well, you should take all that. You should take all that into account. In other words, if you don't do that, you need to be able to justify why.
Also helps tell you how to make the diagnosis, because
Okay.
it will tell you what. Not necessarily for cancer, but I'm thinking about like for exacerbation of chronic obstructive pulmonary disease or pneumonia. What do you call pneumonia versus COPD? I mean, you go through the thing. You ordered lab tests. You look at the lab tests. You look at the chest X-ray. You decide whether the person needs to be on antibiotics. There are different kinds of antibiotics you use for somebody who comes from their community versus somebody who comes from a healthcare facility. And they're not, some physicians do not like them because they do not like to be told cookbooks, or they do not like to be told what to do, but they really have been pretty well checked out and spelled out. And I think in general, they're pretty good.
Well, it's based on science.
Right.
Okay. Now, how does the health insurance companies affect these, the best practices?
Well, health insurance companies have actually Medicare more so attached to the best practices, because Medicare has really created a lot of the quality indicators that we use for seeing how we do. Do you get your aspirin within 1 hour of coming into the hospital when you have chest pain?
Right.
Okay, but most of those were Medicare developed, but the insurance companies haven't used them too.
Okay.
So a lot of them are just good reminders, because sometimes it's just physicians in the whole haste of things forget. May not always do everything in the way that in order.
The problem with the insurance companies is that they stay in business to make profits, and so they. The doctors who practice under certain insurance companies are instructed not to give expensive care. They have to try the cheaper things first. I know there's a part in Fix-It where they had to try physical therapy when they really needed a surgery. And I think, Don, your work with in mental health, you know that certain insurance companies want doctors to prescribe the more cheaper drugs, even though the more expensive drug perhaps works better for this particular patient. So the insurance companies are profit-driven, so they do tell doctors what they can prescribe.
They
and
have
what
formularies. They
Right.
set up formularies, and you have to use their formularies to write for prescription.
So does it seem like these interfere with professional ethics?
Well, I think it should be a
health-
medical decision, and it shouldn't be financially driven. So someone with the best insurance money can buy shouldn't get an MRI for something that could be treated with an aspirin. But on the other hand, if you have minimal insurance, the bare bones insurance, which they call underinsurance, then it would be perhaps you get an aspirin, you really need an MRI.
Okay.
So what the insurance company does is it rations care according to the payout.
Okay. And so basically there is this impact on the way that healthcare providers can provide services.
Well, they get in the way. I mean, why? I mean, your health care should be between you and your doctor.
Right.
You really shouldn't have somebody else that you have to call up and have a test approved. If the physician really really thinks you need the test, you shouldn't have to get pre-certification by somebody who's a nurse or someone who's sitting in an outside place. But just sometimes though, I think we also do tend to overdo testing sometimes for people who have more resources. I mean, there's too much over testing too. But I think that the insurance company shouldn't be between you and your patient.
The decision needs to be
right. Yeah, it needs to be. Yeah, it needs to be
physician. Okay.
Right, driven.
Okay. Now, what about Supreme Court decisions or other legal effects on insurance companies, or to the extent there's still HMOs around? How do these impact practice?
Beginning in the 1990s, the early 1990s, the Supreme Court made a number of decisions regarding, they were really gag rules for physicians. One thing, the physicians were balking at rules that they couldn't discuss treatment options if the treatment options weren't paid for by the insurance. And physicians also couldn't.
You mean there might be 3 or 4 different things you could do that could be done, and one of them the patient might actually want. If they heard about it, the physician is not supposed to say that.
Is not right.
That's
it's
incredible.
Called a gag order. There was actually a cover of Time magazine at the time where there was a doctor with a mask over their face, meaning that was their gag. But no, doctors can't discuss treatment options in the HMOs if it's not covered, because who would pay for it. But the other thing is that doctors cannot reveal that they are paid more for giving less care, and in certain. They called them ACOs now, but they were HMOs. But at any rate, the physicians are paid more if they give less care.
But that's not, I mean, the ACOs also are supposed to be paid more if they're based on better outcomes. And then, the problem, a lot of the HMO business went out of, because physicians ran away from the fact that somebody was trying to manage care.
Right.
Like they were getting way too involved. And the basic was that the insurance companies were trying to prevent you from getting care. So why were we paying for health insurance? But I think the ACOs are sort of like the HMOs, but the ACOs came up, accountable care organizations.
Tell me again, the ACLs you're saying?
ACOs, accountable care organizations. Those are the things that are written into the ACA.
Okay.
And what they are groups of physicians where you're supposed to be judged on the better outcomes of your patients.
Okay. Well, hold that thought. We're going to take a break and look from Fix It, and we will be right back.
The more variability that you have, the more entities, provider, payer, insurance manufacturers, and so on, the more chances of error, the more inefficiencies, the more cost.
One of the reasons why hospital bills are so high, why we are charged so much by doctors, is because they have to spend a lot of resources. They have to hire staff who do nothing more than engage in a nitpicking war with insurance companies on a daily basis to make sure that they are getting paid appropriately.
It makes me angry to see so much waste in healthcare, that there are nurses who are pulled away from actually providing hands-on patient care, and they're pulled into administrative duties. And they're pulled into those duties because we have an incredibly complex billing system. We have many different payers in our billing system. We have people who can't pay, people who have this insurance, people who have that insurance. So there's nurses whose full-time job is to help get authorization so that a patient can get the care they need. And that's ridiculous. I would really love to be a nurse without having to think about whether or not a patient can get the care they need, whether or not a patient is sent home from the hospital without the proper medications because they can't afford it, whether or not a patient is going to be able to get a treatment that a doctor recommends because their insurance company won't pay for it and they can't afford it. And it does break your heart.
We, as a small practice of 5 doctors and 1 provider, deal with about 20 different insurance companies at this point. We have a middle office that has 3 people in it and an office manager that deal with essentially insurance issues and payment issues all the time. If I write a prescription and they want more information, my nurse has to call up that company, wait for their telephone system to come up with a live voice, give them the particulars of the patient and the medication, but it's not uncommon that they spend 30 minutes with 1 appeal. So we're trying to figure out the game so that we spend the least amount of time doing that kind of baloney. Every physician spends $84,000 a year just to interact with the private health insurance industry.
Welcome back to Green Time. I'm host Don Fitz. This episode we're talking about broken system, the effects on healthcare workers. And with me I have Mimi Signor and Dr. Pamella Gronemeyer. Now we were just talking about the effects that court decisions have had on healthcare and how that can affect people who work in the healthcare industry. One of the things you mentioned, Mimi, is that there are a gag rule where there could be a treatment option and the physician is prohibited from explaining that treatment option if it's not covered. You know, it could be medically important. We would think that a patient should know various, when I've gone in for treatments, I've asked my physician, well, what are different things that could be done? And what would happen to a physician, say if there were 3 different things, but the insurance only covered 2, and the physician went on and explained the 3rd option? What could happen?
Well, giving the patients choices that aren't reimbursed, that physician could lose their position with that group, with that medical group.
As most of us, there might be several physicians who are with a group, and so if you're signed up with a group, then they would say that you have a choice of these 10 physicians, but suddenly it would be 9 because that physician would be dumped. And so that physician could lose the business.
I think that people believe that the business-friendly Supreme Court just happened overnight. It didn't. We've had a business-friendly Supreme Court for a couple of decades. And they've been making decisions since the early 90s on into, saying that mandatory insurance is legal and that Americans must purchase this commercial product that perhaps they can't afford or don't want, but they have to.
That was more recent, though. That was the ACA decision.
Yes,
right.
But I'm saying that the business-friendly Supreme Court didn't just happen with the ACA. It's been going on for a couple of decades, and it has got worse.
Does the Supreme Court see health in their decisions? Have they seen health care as more of a civil right or a human right?
They don't see it as a right. They see
it
it as a
commodity.
product.
It's a commodity.
As a commodity to be bought and sold, in other words.
And if you don't have, their theory is if people don't have a mandate, they won't be required to buy it. So therefore, people will still remain uninsured. because that's why they fine them if they don't buy it. But all of that was out of the mandate theory was all out of the Heritage Foundation plan for what became Obamacare and was Romney Care. Some people think if you offer a healthcare product and you have insurance, you have to require people to buy it or they won't buy it, and they'll be uninsured, and then we'll be back to where we were before.
Well, of course, a lot of people don't buy it, even under the Affordable Care Act.
Right,
or
but then
Obamacare.
they get fined, is what happens.
They get fined.
But
Okay.
the mandate, what they interpreted the mandate was like a tax. So that's why they didn't get rid of the mandate, because they said it basically was a tax. That it was a requirement.
Okay, well, a lot of people feel like they don't want this care. They don't want the insurance, and they worry about the excessive cost of medical care. Does it happen very much that patients come in who are seriously ill, and they confide with the physician or with the nurse that my family might be better off if I didn't have this care, or if I died, than if they were left with this incredible burden to keeping me alive? Have either one of you ever experienced anything like that?
Absolutely. It happens all the time. And really, the patients I've had are hanging on to 65 to get Medicare because they know they can't afford the care until then. And even though Medicare doesn't pay the full bill, it pays a good portion of it. And so you may need heart bypass surgery. You may need a lot of different things, but they're praying that they just live to be 65 so they can get health care, because otherwise they know that they can't afford it. And the patients that I have had that are uninsured, they're embarrassed that they're poor.
Right.
And they apologize.
Uninsured or underinsured?
Uninsured.
Okay.
I do sometimes see uninsured patients that come through the clinics and they get permission to have certain testing. And they are very embarrassed that they can't afford to buy health insurance, and that's what we have done to the poor. We have made them ashamed
it's very stressful
that they're
for people
poor.
Working.
And it's horrible. But insurance is not inexpensive, and if you have to worry about your bills and sending your kids to school with shoes and feeding them breakfast, and then you have this other layer.
Okay. One question I wanted to get to was, Dr. Gronemeyer, you believe that the single payer could help small businesses, and how could that be the case?
Well, it could clearly help small businesses, because right now we have to purchase a product from an insurance company. And I would just much prefer writing, I prefer, and some people don't necessarily think, but I would prefer writing a payroll tax just like I do for Medicare, and then my employees would pay a slightly increased tax, which would cover their copays and deductibles. Because I think right now, that if single payer, single Medicare operates on like a 3% overhead margin, 3% administrative costs. Insurance companies, are now supposed to be like 15% of administrative costs, but they're somewhere between 15 and 30, because all those administrative costs include salaries for the CEOs,
right,
all the perks that they have, the advertisements they do when they wine and dine people who go into Medicare Advantage plans. So single payer, from the minute you're born, you would have a card that said that you had health care. And it would be, everybody would be the same. So you could go from job to job with that card. Your insurance wouldn't be dependent on your job. And you'd always have it. And it also would take the burden off the fact, because right now, but for my health employees, I was paying up to $120,000 for health insurance for my employees.
That's amazing. How many employees?
I have 7 employees.
720,000 is a lot.
Well, I give them good insurance because I'm like, and I think many small businesses are like me, and then we think our employees are our most valuable commodities. No, not commodities. They're our friends. We work with them.
Right.
They're our friends, and they're very important to my business. So I view their health as very important to me. So
Okay.
I want to give them something that that they can use and benefit from.
Let's take a break. We're going to see a short comparison between U.S. and Canadian healthcare systems and then be right back.
The data shows very compelling information about single-payer systems. And so it was imperative that we visit a single-payer system and experience what life was like on the ground. Fortunately, we've got a single-payer system operating to our north in Canada.
I found that I was really quite unencumbered when it came to seeing the patients, that I could concentrate on doing medicine and not worry about other things. And that was quite a change from what my experience had been. I worked in community health centers in Oakland, California for many years. I was the medical director there and the medical director also of a consortium of community health centers also in the East Bay area. I left there in 2004 and moved to Canada. Sometimes when I'm driving around here, I think, oh my gosh, I'm back in a Marcus Welby episode or something. First family practice department meeting that I attended here in Canada was quite an experience. People actually seemed happy. No one was talking about the latest outrage that had occurred from some insurance company. No one was complaining that they couldn't see their patients anymore.
As a Canadian physician, I sort of laugh when I hear people talk about government, telling me what to do or government-run healthcare. That's certainly not been my experience of working in the Canadian healthcare system. I have an enormous degree of clinical autonomy.
People seem to think that because there's a single payer, that you are working for the government. You're an employee. They tell you what to do. Nothing could be further from the truth.
Just take a listen and see how blood pressure's doing today.
I'm in practice. I'm a small business person. They're not running my business for me. They don't come in and review me and tell me, you're not doing this right, you're not doing that right. They're the ones that pay me for the work that I do.
This is what I do to bill for one patient. I bring up the patient, click on new, type in the codes, a billing item and a diagnosis code. The date is already filled in for me. I create bill and it's done.
It is very simple. Basically, you come in, I see you, I send off a bill. 2 weeks later, there's money in the bank. Patient doesn't have to pay.
Welcome back to Green Time. I'm host Don Fitz. We're talking about a broken system effects on healthcare workers, and with me I have Dr. Pamella Gronemeyer, who has her own business, and I also have Mimi Signor, who is a registered nurse with Missourians for Single Payer. Now, it always amazes and depresses me to think that when we're talking about the cost of health care and the belief that how expensive it would be with single payer, that a lot of people do not take into account that we have between 15 and 30% added expenses just to pay for insurance. And so immediately with the single payer, we would have a huge decrease in not having all of that extra expense. Dr. Gronemeyer, what would you like the viewer to take with them?
I would like the viewer to take with them the fact that they need to really, there are many ways to learn about single payer and healthcare reform. We have many websites you can go to, but I think realistically, many physicians are we've had it with insurance companies. We really think that we really need to have a system where we can decide what our patients need and we can treat them.
And the physician needs to
The physician needs to be in charge.
Okay, Mimi Signor, just a few seconds. What do you think the most important thing to remember?
I think the most important thing to remember is that health care should be appropriate. And what we have now is if you're affluent, you can get the best health care money can buy. It might not be appropriate.
Mimi, I got to cut you off.
Okay.
I want to thank both of you for participating in this discussion. I want to thank our viewers for tuning in, and be sure to watch it same time next week.